Rishi sir, please start.
Rishi sir.
Rishi sir, are you there?
Unmute
Unmute,
करा
sir.
Rishi साहेब.
Unmute yourself,
Yes, yes.
Rishi sir.
Kindly
Yes,
unmute.
yes. Yes,
thank
yes.
Rishi.
Good evening to all. Respected Bodhankar sir, Dr. Nitin Shah sir, and all seniors, Dr. Sanjay Pakmude sir, Dr. Amol Pawar. I welcome you all for this vaccine samvad. There is a panel discussion on newer PCV vaccines. This is the third episode, which from the Maharashtra IAP. So I welcome you all. We have all the good moderate stalwarts and delegates from a good team. So I welcome you all. First of all, I request Dr. Pakmodi sir to address the online delegates.
Namaskar. Good evening. Good evening, respected Dr. Bodhankar sir, respected Dr. Nitin Shah sir, and all the other stalwarts who have joined for the today's Mahavaccine Mahasamvad. And today's panelist, Dr. Chetan Trivedi from Ahmedabad, Dr. Manish Kulkarni from Chhatrapati Sambhajinagar, and Dr. Jitendra Gavhani from the Navi Mumbai. We know the immunization is a very important topic, and since last 3 months we have started this vaccine Mahasamvad, and we got a huge response. This is because of a man of national and international repute, Dr. Nitin Shah sir. When sir is there and we are getting too much information every monthly from particular vaccine every monthly, so rather than reading the books, so we get updated in the span of 1 hour or 1.5 hour, and we get a lot number of information, and that too what we have read in the what we have read and what are the newer updated informations available. So that is a very good thing on the means this program is really a very important thing, and that we are doing this the particular thing on the every Friday, first Friday of every month. So today's topic is a newer pneumococcal vaccines. I think where panelists are very good panelists from this time we have got, and then we know the program runs like anything, and immunization is a very important thing, because we know with the time we have seen there is a newer antibiotics. Making the newer antibiotics is really a difficult thing, but possibility of making the newer vaccines is really immense, and we already know that preventing the disease is rather better than treating the disease. So I think with this short introduction, I hand over the mic to the Dr. Rishi.
Yes. Thank you, sir, for addressing for the delegates. I now welcome Dr. Amol Pawar to address the delegates.
Thank you, dear Rishi sir, and thank you for consenting to be as a as a MOC for today's webinar. First of all, I welcome our chief guest of honor for this webinar, special webinar, Dr. Uday Bodhankar sir, who is the youngest president of National IAP in the history of National IAP. He is leading in that table. Then again, President, Dr. Nitin Shah sir, 3 months back he consented Dr. Sanjay Pakmode sir that he will take this program ahead for total 1 year, and this is third episode, and we will be continuing this thing, and 11 episode we'll try to complete. We have galaxy of speakers for each month, and there are almost 25 to 30 speakers he has sorted from all over India, and they will be taken by him in successive webinars. Then today's panelist, we all know Dr. Manish Kulkarni ma'am. She's from, actually nowadays, she is more sorted faculty in vaccinology than her husband. So he is also a vaccine expert, Dr. Ganesh Kulkarni sir. And then next is Dr. Chetan Trivedi. He is also the most sorted faculty across India in all zones, in all conferences, whether it is Vaccicon or any ID conference or other state conference also. So welcome Chetan Trivedi sir. He is president of Gujarat IIP also and ex-CB member of Central IIP. Also third panelist, my dear friend, mentor, Dr. Jitendra Gawani sir. He is again one of the senior IIP member from Navi Mumbai IIP, and he is also working for Indian Academy of Pediatrics in his own capacity. And also I welcome other people from other states like Dr. Jalil Ahmed sir, Dr. Singar Velu sir, then Dr. Agrawal sir, Dr. Nehal Patel madam, my co-EB of last year also and this year also, and other delegates who have joined this webinar on your TC vaccines from all over India and as well as from Maharashtra also. So it will be a happy learning for all of us. Next 2 hours, you have to be ready with many of the newer this thing from Nitin Shah sir. So over to you, Rishi Lodaya sir, for further proceeding.
Yeah. Thank you, Dr. Amol, for guiding and nice address. Now I welcome Dr. Sanjay Deshmukh, convener of MAHAIP, to address the delegates. Dr. Sanjay Deshmukh.
Good evening.
Yeah.
Good evening. As a convener of MAHAIP, we are very fortunate to have such an academic activity this year under the leadership of our President Dr. Pakmade Bhau and Dynamic Secretary Amol. And rightly said by every dignitaries, under the mentorship of our vaccine samrat, Dr. Nitin Shah sir, we are very fortunate he has consented for this series. Thank you, Dr. Nitin Shah sir. And today we have the galaxy of speakers across India. Dr. Chetan Trivedi sir, one of the experts in vaccine and infectious diseases. Then our own Jitu Bhau Gawane and Dr. Manish Kulkarni madam from Chhatrapati Sambhaji Nagar. So it is a blend of expertise with the guidance of Dr. Nitin Shah. I hope today's session on the pneumococcal disease will give more insight in the vaccine, and wish you all the best for the academic activities, and welcome all the office bearers of Central IIP and Maharashtra IIP. Thank you.
Yeah. Thank you, Dr. Sanjay. So now, without wasting much time, we will start the session. For this today's session, we have our chief main Dr. Nitin Shah sir as a moderator, who is a head of the pediatric in PD Hinduja Hospital. He is also honorary pediatric hematologist oncologist at Vijayawada Hospital and visiting pediatric hematologist oncologist at Apollo Hospital. He was the president of IAP in 2006. He has editor for several books like Textbook of Pediatric Hematology, Oncology, and many special series books. He has delivered more than 2,000 guest lectures, orations, and published more than 100 articles in various journals and books. So I think he needs no introduction rather than this. So I welcome Dr.
Wait. We have a guest of honor, Dr. Uday Bodankar sir. So,
Yeah.
So we have to introduce him. So I will just introduce him, and then we'll have his his words of wisdom, and then we'll go ahead.
Don't have problem.
Okay.
I'm
We
not.
Dr. Uday Bodankar sir as a guest. Yeah. Okay.
I will introduce him. Wait, sir. So we all welcome Dr. Uday Bodankar sir, today's guest of honor.
Yes, sir.
He is former honorary professor in pediatrics at IGMC Nagpur. He was honorary professor of IMA also. then former standing committee member of IPA, former national president, that is youngest president, and then former member of Advisory Council of Government of India.
Thank
He
you.
has long list of his this thing. He is executive director of OMAD, UK. So I request Dr. Uday Bodhankar sir to give his words of wisdom.
Yeah,
Over to
thank
you,
you,
Dr.
Dr.
So
Amol.
before that, just one correction. He is still the youngest president by heart.
Thank you, Nitin bhai, for that compliment, which I don't know I deserve or not. Anyway, thank you, respected my brother, my mentor, a person whom I refer for any complication or suggestion for vaccine, Dr. Nitin Shah sir, Dr. Sanjay Pakmode, who is from my own city and most dynamic patient of Maharashtra State IIP, Dr. Amol Pawar, who was after me in 3 days, 4 days. I said, don't put me. I'm not expert in vaccine, but he wanted me to be here. Thank you, Dr. Amol. Of course, we have got here the main speaker who are there, Dr. Rushi Lodaya, who worked with me in my hospital, Rushi, and Dr.
Yes,
Sanjay
yes.
Deshmukh, and all. The today's speaker, I know all of them by heart. Dr. Chetan Trivedi, who doesn't know, from Ahmedabad, from city of Honorable PM Modi. Dr. Yeah. Dr. Jitu, we call him Jitu, Jitendra Gawane, whom I know very well, as the most dynamic, vibrant EB of IIP. And of course, Dr. Manisha, I was not knowing. I know Dr. Ganesh by heart. My birthplace is Hyderabad, but my home place is, sorry, Sambhajinagar, not Aurangabad. So I belong to Aurangabad, Hyderabad, and Nagpur, 3 places. So, Manisha, today's Samvad, which has been given as a newer vaccine, it is going to be a brainstorming with a internationally known stalwart, Dr. Nitin Shah, and all of you. I would not like to take much time, but I would like to say few words of wisdom with the permission of Dr. Nitin Shah. You all know that the newer vaccine, pneumococcal conjugate vaccine, include PCV15 and PCV20, and with PCV21, which has come recently approved for adult, for offering broader serotype coverage and improved protection against invasive pneumococcal vaccine. Now, I think they will go into detail in newer pneumococcal vaccine. Like, I don't know whether they are going to talk adult vaccine like PG15, 20, 21. The only thing, the advantages which I could see of the newer conjugate vaccine is they have got broader serotype coverage, improved protection, and targeting specific. So in short, PCU21, which is a particular design to target serotype that causes the majority of IPD cases in adults, making it a valuable tool for in reducing the disease incidence in this question. In summary, the newer PCU conjugate vaccine represents a significant advancement in pneumococcal vaccination, offering broader protection and improved targeting of disease causing serotype, particularly in adults. So I think with this preamble, I'm not sure whether I am correct. Dr. Nitin Shah will correct me. I would like to hand over to the boss of vaccine, Dr. Nitin Shah. Thank you very much.
1 minute.
Rishi, continue with
Yeah,
introduction
yeah,
of
yeah.
others. Quickly, we can
Yeah,
start
yeah.
then.
Thank you, sir. Thank you, Bodhankar, sir, for addressing us. After introduction of the Dr. Nitin Shah, sir, he was the chief moderator. Now, we have three panelists: Dr. Chetan Trivedi from Ahmedabad, who is a senior pediatrician and ID consultant, Neha Children Hospital at Maninagar, Ahmedabad. He is ex-honorary assistant professor and infectious disease consultant. He was president of AOP Gujarat 2023, organizing secretary of IPA Pedicon 2023. He was executive board member, secretary of IAP ID also. He is a scientific convener. He was past president of AOP Ahmedabad in 2013 and 14, and he has authored chapters in many books, and he is national trainer for many central IIP modules. So I welcome Dr. Chetan Trivedi as one of the panelists. Second
Thank you.
one, Dr. Jitendra Gawane, who is a batchmate and friend of mine. Dr. Jitendra Gawane is professor of pediatric and PICU in charge from MGM Medical College, Navi Mumbai. He is executive board member, Central IIP 2023 and 2024. He is a consultant pediatrician of MGM Hospital in Vashi, Navi Mumbai, and he is has author a chapter in 5 books 12 international and 22 national publication. And his area of interest is pediatric intensive care and vaccinology. So I welcome Dr. Jitendra Gawane, also as one of the panelists. And the last Dr. Manish Kulkarni, whom today only I came to know regarding the Manish Kulkarni madam. She is the assistant professor of pediatric uh, at Badnapur. She is consultant pediatrician at Sanjeevani Children Hospital at Chhatrapati Sambhaji Nagar. And her area of interest is childhood nutrition, lactation, vaccinology, and pediatric rheumatology. So I welcome all the panelists also. And thank you. We can start. Sir, Dr.
Rishi sir,
Yeah.
let me welcome today's MMC observer,
MMC
Dr.
observer. Yeah.
Dr. Vivek Randive,
Dr.
sir.
Vivek. Yeah.
I think
He
senior.
has joined.
Actually, he's senior pediatrician from Mumbai. So, Vivek sir,
Yeah,
do
yeah.
you want to have some words at this point? Vivek sir, please.
We have one MMC point for which we have a MMC observer, Dr. Vivek Randive. He is a senior most pediatrician at Mumbai. Sir, Dr. Vivek sir is there?
Yes, he is there. So, Vivek sir, if he is not there, if he is busy in OPD, we will take his opinion at the end then.
At the
Yeah.
comments.
We can start. Yeah.
So, Nitin sir, please start.
Yeah. Okay. Fine.
Over to you, Dr. Nitin sir.
Yeah, thank you everyone. Thank you, Stalwart, Dr. Bodhankar. I see several familiar faces. I see a lot of people whom I know. They are all there today, and we have record 386. Probably we'll touch 400 very soon.
That only because of you.
No, it's not because of me. It's because of vaccine. Because I'm sure so many new PCVs are there.
Yeah.
People want to know how to use
Yeah.
them best. So I have an excellent galaxy of panelists. I have Dr. Manish, who I said she's like a bullet of data that she will blatter out without referring to any page or any piece of paper. We have Dr. Jitendra Gawane, with whom I have shared many times immunization dialogues. And Chetan, of course, is a master of infectious disease and also a great vaccine expert. So let's start with some general. And so, by the way, we had the PCV7, which came in 2005 in India. In 2000, it was part of national program in USA. Then came PCV13, which replaced PCV7 world over. And meantime, we had GSK's PCV10, which also came. So we were having only two vaccines, PCV10 from GSK and PCV13 from Pfizer. And there were a lot of vaccine serotype difference, cost difference, etc. So we were even struggling and debating that time. And then came our own two new vaccines, the 10-valent vaccine from Serum Institute of India, which is, as I call, a global vaccine made locally. Then we had a 14-valent vaccine which came from biologically, which had some extra serotype. We'll discuss all that. And we were just settling down as to how to now incorporate these two vaccines. We have now not one but three brands of the same vaccine. Another PCV13, which is marketed by three companies, Lupin, the original researcher in India, Vaximune, and also from DRL, that is Reddy's Laboratory, along with Sanofi. So three more, and that makes it 7 vaccines available. We have a 15-valent vaccine for MSD, which is banging the door. We have another 15-valent vaccine, which is little different from Aurobindo, which I don't know when it will come. We have a 20-valent vaccine from Pfizer available internationally and likely to come in the second quarter of next year. And we have a very unique 21-valent vaccine from MSD only for adults in USA. And last but not the least, our own biologically is working on a 23-valent vaccine. I mean, this is an endless game, and we are going to have debate again and again. So let's see, how does a pediatrician then use a vaccine in the day-to-day practice? Because as you know, the PCV10 from Serum and PCV14 from biologically have replaced PCV13 of Pfizer in the national program. But in our practice, we have a lot of choices. So first, some general principle, understanding what is immunogenicity studies, because that's based on which these vaccines are licensed, and the schedules. And then we will touch upon individual vaccine, their merits and demerits, so that we can then take a call as to how best to use. So let me start with Dr. Jitendra Gawane, and I will ask you some set of questions on the general principles. So number one, what is serotype coverage for IPD, that invasive pneumococcal disease, and do we have any recent data, or are they just some 10-15 year old data?
Good evening, everyone. Thank you, sir. The vaccine which we are going to use, we should have a knowledge about what serotypes are prevalent in our country, so that we can use the optimum use of vaccine containing those serotypes, so that we get a maximum protection against invasive pneumococcal disease. So various studies has been done in various parts of the world, but coming to India, we have at least 4 studies done here locally. That is a basic study, ASIP study, then PDOF study, also like a pan-India distribution of pneumococcal serotype study too. So all these studies are showing a more or less similar picture, where we have maximum of serotype 1, 14, and 5, which almost 14 to 15%. And then we have serotype 19F, 23F, 6B, almost 10% of these all. And then we have 19A and 9V also, which is contributing around 5%. Rest of the serotypes are 2% to 3% or less than 1%. So various studies are done, and this data is recently published also in Lancet 2023. So it is a robust.
So how recent are these studies? ASIP basis, you said
ASIP
there's a
basis,
review
sir,
by Jyotsna's group, which was last 15 years, which is like 1,000 plus isolate. Nisarga's
Right.
group, small numbers, and there's one more from Vellore. So these are all how many years old already?
So ASIP and ASIP started in 2013 and published in 2017, and Vellore
So almost
studies
10 years old, each one
yeah.
of them.
Right, sir.
We don't have any very recent data.
Yeah, PDOF study is one which is ongoing kind of thing, and PDOF 2 is ongoing, sir.
All right. So second question to you is, what is the immunogen? Like people talk of primary, booster, long term. What
Right.
are those pictures?
Yes.
I mean, when people read, they get confused as to what is this.
So immunogenicity of the vaccine means the antigen, how much antigen is producing the antibodies that response to the antigen, we call it as a immunogenicity.
Okay.
And at the end of the vaccination, we always look at after primary series and after booster series, how much protective antibodies are formed, that we measure.
So a month after the third dose would be the post primary.
Yeah. So in case of PCV, after third dose, 1 month after third dose, if we are doing the titers, that is called as a primary post primary series, and then 1 month after booster dose, if we are doing, that is a post booster study. And as I was
long term data.
Yeah, so
long-term data?
Long-term efficacy, effectiveness data is available for the older vaccines which are there, and this is published in Lancet, where Gambian study is published with where neck-to-neck comparison is done between.
So we will come to those individual vaccines, but in general principle, immunogenicity is the most important.
Yeah.
When it comes to licensing, and also for us to have confidence in using the vaccine.
Right, sir.
What about the safety? How much credence you give to safety?
So whenever we are thinking of planning of introducing any vaccine or developing any vaccine, the first and most important thing what we look at is the safety. Correct. So unless safety trials are passed, we cannot go to the other immunogenicity or efficacy trials, and nothing can be done without any safety trial. So all these vaccines which are seeing the day of level 3 and all, already they are safe vaccines. So safety is the most important thing in terms of vaccine development.
Okay, how much weightage you give to the cost? Suppose you have two not exactly same but little similar, plus minus 10%. Cost matters, or you still go by the science alone?
So, sir, we have to see first is, as we said, safety, then immunogenicity, then non-inferiority to the established vaccine. So these three are the most important thing, and once these three criteria are fulfilled, then we will look at the cost, which one is having cheaper in fulfilling these criteria.
Okay, and what about then vaccines which are in use in different countries in the national program? They have the impact data, what you call effectiveness data, which means once they start using it in NIP, what happened to before and after the introduction? Does such data matter, or because the new vaccine always will not have such data as compared to existing vaccine? But does it matter, or just the immunogenicity comparison between two, which is very similar? You presume that is an immunobridging to the data with the existing vaccine.
So definitely the effectiveness data is the real world science, where after introducing vaccine in, it's like companies giving average of 28, but in real sense we get average of 20 only from the vehicle. Similarly, effectiveness is same when when the efficacy studies are showing that it is 90% effective, but real world data which is generated over a period of use of the vaccine will tell us exactly how vaccine is working. But
no, my
this
question
cannot be
was,
true.
if you have
This
two
can
vaccine, one old and
absolutely,
one
sir.
new, old
So
has lot of data, new is just come,
just
but
emerged.
it's very similar immunogenically and safety wise. Would
Right.
it
Yeah,
matter that they don't
so
have the impact data?
for life-threatening diseases, we cannot wait for the effectiveness to get it done. So we have to compare with the established vaccine, which is we have to prove that it is non-inferior to the present one.
So
And once
that's on
that is proven, then
immunogenicity.
over a period of time, we will see the effectiveness.
So that's on immunogenicity.
Yes.
So impact data is there, it's a plus point, but if it's not there, doesn't mean
Absolutely.
it's an inferior vaccine. Okay,
Yes.
last two question on general aspect. How do you select a new PCV? That's the main crux of the discussion today. Country of origin, Pandora's box. You have two very similar vaccine. One is from India, one is from abroad.
So obviously, we will.
Or one is from China.
Obviously, we will see first safety, efficacy, and
all that is seen. All that is seen.
Yeah, and then secondly, next important thing is about the affordability of the patient. We will see, and then of course, if all these criteria are fulfilled, then definitely we will go for made in India vaccine. Definitely, sir.
Okay, and a lot of people talk about is my vaccine WHO pre-qualified. Mine is not pre-qualified. What is this WHO pre-qualification and presence of pre-qualification? Does it make it the vaccine better, or what is this pre-qualification about?
So WHO pre-qualification is a very stringent process where WHO sees many quality parameters of development of the vaccine, how it is produced in the industry. They visit the site multiple times, and after that they look at the safety, immunogenicity, and non-inferiority. But before that, all these stringent criteria by the
good
team
manufacturing
of the WHO
process is ascertained, and then the data on the scientific studies, and suppose they are then satisfied, they'll make it. So what does pre-qualification mean?
Pre-qualification means now that vaccine is can be procured by the various government agencies and Gavi
and UNICEF
and all. Yes, sir.
So if a vaccine not WHO pre-qualified because it didn't apply, it doesn't mean it's not a good vaccine. It's not a standard like ISI mark that this means this is good and this is not good. All right, perfect. So I think we have discussed lot of credence what to give when you select a new PCV, and for that matter any new vaccine, but discussion today is PCV. The number one is the safety and immunogenicity data. Number two is the impact study if possible. Number three is the cost. Number four is the country of origin. Last but not least, if you WHO pre-qualified, you don't have to break your head because someone else has broken head for you and decided that this is a good vaccine. All right, now let's understand from Chetan. Most important, as Dr. Jitendra kept on mentioning again and again, that we must have a new vaccine which is immunologically non-inferior, right? So you have vaccine with 10 valent, 13 valent, 14 valent, 21, 20 valent, and you are not going to study impact of every serotype on the disease. I mean, it's humanly impossible to do that. So how does a new vaccine come in the market now that you can't have a field efficacy trial because one, they are expensive, two, because they're ethically not permitted to have a placebo arm, and number three, they are not possible in developing countries, and developed countries already have an existing PCV. So how does a new vaccine come in the market?
Yeah, good evening. Yes, because we know that suppose if new vaccine is coming into market and we have officially effective vaccine which has been licensed, so no need to go for placebo controlled efficacy trial, because we know that, as you said, because it is not ethically as well as practically permissible. Correct. So what you have to show is there is a non-inferiority to the existing brand. Now it can be existing brand which may be in the government national immunization schedule, or it is in use in the country. So wherever it has been going to come into market, they have to prove the non-inferiority. But that non-inferiority, we have to have certain criteria.
So that is that. So basically, it is new vaccine license based on a immunological and safety study and does not have to undergo necessarily a efficacy trial. In fact, for that matter, PCB 13 from Pfizer also was licensed based on non-inferiority
Correct.
compared to PCB 7 for the 7 common serotype, and PCB 10 of GSK also was licensed based on non-inferiority compared to PCB 7 for the 7 common serotype. So you don't have to have an efficacy trial for the new vaccine. So what do you look at? There is something like IgG and something like OPA, and then you have IgG seroconversion, IgG titer, you have OPA seroconversion, OPA titer. So what does this word mean, and how do you look at it when you read a new article?
Right. So when you talk about IgG, we know it is a immunoglobulin or antibody, right?
Correct.
Here, when we are talking in context of the pneumococcal vaccine.
Correct.
So here, IgG is a serotype specific antibody against the pneumococcal polysaccharide antigen. Now, this has been measured by
Conjugated.
ELISA.
Conjugated polysaccharide.
Yeah, pneumococcal conjugate polysaccharide.
Correct.
And here it has been measured by ELISA. Now, this immunoglobulin measures the quantity of antibody. Okay,
Correct.
so that is GMC. That is one thing. Now, this IgG, similarly, we can have OPA. Now, what is OPA? It is
so one minute. So as I understand, you said IgG is by ELISA, which is a chemical method of ascertaining an amount of antibody specific to a particular serotype. It may or may not be effective. Is that what I'm trying to say?
So I'm coming to that. See, it is serotype specific antibody level quantity.
Correct.
So that doesn't mean it is going to be effective.
So how do you know it's going to be effective?
So for that, I think there is a OPA, which is a functional bactericidal antibody response, which is measured by opsonophagocytic activities. That is OPA.
So how do you do that?
So that is basically, suppose you have a vaccine, right? So the person who have been vaccinated take a serum and you have antigen, and you mix it and have a complement.
So you have the particular serotype.
Serotype.
A live organism. Like say, let's take 19A. So
Yes.
you take the serum of a vaccinated child, put 19A live pneumococci, add human complement, and then do what?
So you add complement, and then you gradually keep on increasing the titer which is required to kill 50% of 19A.
So dilute the serum of the vaccinated
child. So keep on diluting, and if you have a titer which is required 1:8 or more, then it is the OPA is sufficient or enough to gather protection. So this is the OPA seroconversion. So once you have a titer more than 1:8, it is OPA seroconversion. So OPA is this considered as a sort of a real functional antibody. So that has been quality of antibody, right?
So why is it that the Drug Control Journal of India, or for that matter any drug control in the world, does not look at OPA before licensing? It just license is based on IgG response alone. I mean, is that not an anomaly?
Yeah, that is true. But what way they consider is IgG is also equally important, because we know that when we want to get protection with the PCV, we have to one circulating antibody which will take care of the antigen once it enters the circulation. But if you want to decrease the nasopharyngeal carriage acquisition, at that particular time you might require something called the memory B cells. Now, how can you know what is the level of memory B cells? That you can do by serotype specific IgG assessment, and that will give you a rough idea. Okay, this is memory B cells are there. That's why it is important. But direct protection, if you say, it is a OPA titer, which is surrogate of the functional humoral protection.
Correct. So as I understand, IgG is a chemical way of finding out an antibody. Most of the time, it means they are good antibodies, but not necessarily. Whereas OPA actually tests the ability of the antibody to kill, and that's why it's more important. I think to clinician, OPA is more important. For the drug controller or the licensing authority, IgG is enough and probably more important. Just to give you an example, you take PCV7, which has 19F but not 19A, and yet it generates in 85% subject an IgG response to 19A. But when it comes to OPA, functional antibody, it is almost zero. And that's why you saw the story that after use of PCV7, 19A went out of hand. Whereas if you just believed on IgG, you would have said, okay, 19A should work. So I think that's important, that you should look at both, and OPA more as a clinician. Now you are saying non-inferiority. So now when you compare a new vaccine with an existing vaccine, on IgG, what are the non-inferiority criteria? Because there are no criteria on OPA by the licensing authorities.
So there is very important thing we have to understand. When you are talking about non-inferiority, two things we are looking at. One is a percentage of responder with IgG concentration, whether it is equal to or above the surrogate value for protection, which is measured, say, 1 month post primary or post booster.
Correct. What is the cutoff taken there?
There is different cutoff. Suppose, and second point is serotype specific IgG GMC. So that is also been calculated. So
Correct.
if you talk about percent of responded, suppose you have given n number x 100 people vaccine. Out of that, how many percent they get seroconverted and having a cutoff above the correlate of
So
protection?
what is that cutoff?
That cutoff is for PCV, it is 0.35 microgram per ml.
Correct. So it's an
So if
arbitrary figure of 0.35. It may not be sacrosanct for every serotype. It may differ serotype to serotype, but for some semblance of order, 0.35 is taken by WHO as a gospel truth to say a new vaccine should show a good sero response above 0.35. So now on a seroconversion difference, what is the non-inferiority criteria?
So this particular 0.35 microgram has come from PCV's 7's original data.
Correct.
And there it is absolutely arbitrary because there are variation in a population as well as the serotype also. But still they have for uniformity, they have taken a 0.35 cutoff.
Correct.
Now what they say, this difference, suppose you have new vaccine, which is having 90% seroconversion. And the old vaccine is like 93% seroconversion.
Correct.
So what is the difference? Difference
Minus
is 3%. Minus 3%. Now
Correct.
you take 95% confidence interval for 3, right?
Of these
It
minus
came-
3.
So minus 3, you may have something like lower limit of the confidence interval and upper limit. So
Correct.
when you see the lower limit of confidence interval, suppose minus 3, if it is say minus 5, right? So it should be above minus 10.
10, correct.
Right?
That
So
means
if it
there
is,
should be not more than 10% difference on the minimum guarantee of the seroconversion with the new vaccine vis-a-vis the old vaccine.
so this is absolutely lenient thing, because if you compare again second point, that is a GMC titer.
Correct.
So
On
there we
GMC
have to do a
titers, yes.
ratio of new
So I
vaccines.
give you an example. The new vaccine is generating at titers of 1.5 and the old vaccine at a titer of 2. So you divide 1.5
So
by
1.5 divided by 2.
So
What
that
it will
become
come? Suppose whatever it comes,
0.75.
0.75. You take a 95% confidence interval of that.
Correct.
So
Suppose it's
maybe
0.6 to 0.9.
so now this 0.6 is above 0.5.
Correct.
So
it should
what
be
is
at least
required
half.
is the ratio more than 0.5. So new vaccine, if it is having the titer just 50% of the existing brand,
Correct.
then also it meets the non-inferiority
Correct.
criteria.
Correct. So I think this is important to understand because the new vaccine did not have exactly the same immune response. Even if it is as good as half the existing vaccine, minimally, then that's licensed by the Drug the Drug Control General of India. Now, is there any such criteria for the OPA?
No, there, because it is not been required for licensing authority, so they don't put it. But what companies they do it, they just do measure the OPA seroconversion. Like how many percent of the patients vaccine they are having above 1:8 titer.
So it is
And
just
that,
an observation of the values.
so they
There
will
is
just
there is
compare
no
it with,
statistical comparison.
yes, it is head-to-head comparison. Suppose this particular brand is having 90%, another is having 89%. So that is different. So they are almost same.
Perfect. So what we have learned so far, first we learned from Dr. Jitu that when you select a PCV in your practice, it's a new vaccine. It is compared with an existing vaccine for which you have an efficacy data, so you are immunobridging. It should be immunologically non-inferior, safe, cost-effective, any possible WHO pre-qualified. And last, if everything fits in, then if you are from the country of origin, which is your own country, because every country would defend. I mean, you are seeing today what's happening with the tariff fight, that everyone wants to protect their own country. And then we learned from Dr. Chetan that the most important of this is the immunological non-inferiority, which is based on IgG seroconversion should not be below more than -10, and on titer it should be at least half or more than the existing vaccine. And for clinician, looking at the OPA titer, which are functional antibody, though there are no criteria of inferiority, but a good OPA seroconversion and a good titer visually would give you confidence that this vaccine is going to be good. Okay, so after these two general principles, let's move to Dr. Manish. She's keeping quiet for a long time. Dr. Manish, welcome. I want to discuss with you the schedule, because see, we are using 3+1 schedule as per the manufacturer in the private practice. The EPI is using 2+1 schedule all over the world based on the WHO. We start 6, 10, 14 plus a booster at 15 months. The EPI says 6, 14 and early booster at 9 months. There are countries like UK, we started with 2+1, 2 months, 3 months, 12 months. Now they give only 1+1, 2 months and 12 months. There are some countries like Australia which has started with 3+0 without a booster, and they used to give booster of the PPSV 23 before they switched to a booster also with conjugate, and they drop one primary, and all sorts of combinations are being used in the public health because they want to say one dose saved is like, you can imagine how much. So I want you to tell our viewers, is 2+1 schedule enough? If yes, why?
Seeing all the data, you can say there cannot be a single perfect PCV schedule which fits all the needs of all the countries, all individuals at the same time. And
Correct.
I said that all the three schedules, 3+1, 3+0, 2+1, they are all immunogenic and can be used in the public sector. So
Perfect.
policymaker considers in implementing this PCV schedule in the national program, he has to see the epidemiology of the disease in the country, the cost effectiveness, and all
Correct.
the schedule which is already existing in the national immunization program.
Correct.
Now, the gold standard is considered as 3+1 schedule. This is
Correct.
because it has been studied most extensively. This was
Correct.
based on the licensure studies when PCV7 was first launched in USA in 2000. So we have got 2 decades of robust data that it
Correct.
okay. But in a country like India, where there are limited resources, the cost is the main hurdle before.
Oh, including the entire Europe, not only India.
Ah,
They use 2+1.
Oh, yes, sir. So we searched for the different schedules which were cost sparing and dose cutting, and we studied for the effectiveness. India, as we
Correct.
all got a huge disease burden, and it peaks during the 6 months to 11th month, early peaking of the disease per se, and also
Correct.
serotype 1 is important. India
Correct.
for this 2+1 schedule where 2 doses are given at 6 weeks and 14 weeks, 2 months apart, and a booster dose was given at 9 months.
Correct.
See, this is a variant of 3+0, which was
Correct.
studied in 2 large efficacy trials conducted in Africa. There's a Gambian study and South African study, where when they use this 3+0 schedule with early 3 primary doses given at 6, 10, and 14 without a booster, they found that schedule is effective and that protected the children up to almost 6 years of age. But
Correct.
it didn't protect for serotype 1. And because the vaccine offered protection was short-lived, and if you see the epidemiology of serotype 1, it peaks or it affects slightly older children at around 18 months. So
Correct. So
they
the booster is the most important of the all 4 doses.
African countries have shifted to 2+1, and they found that there was a decline in the serotype 1 cases by almost 57% for children less than 2 years.
Perfect.
For the schedule of 2+1, because they wanted a longer duration of protection and also to maintain the herd effect for a longer time. And
Correct.
the main driver for considering these PCV schedules is the schedule of the vaccines which are already there in the national immunization program. So it's
Correct.
easy to incorporate the PCV vaccines when during that healthcare visit, when the patient is visiting for some other vaccine. So it becomes easy
Correct.
for the vaccine provider as well as the parents because there is no new visit created.
Perfect.
So consolidating the vaccines in a fewer visits, the compliance is good and also the vaccine coverage is better.
So piggybacking on the existing vaccine schedule.
Yes, sir. We had a Penta at 6 weeks and 14 weeks, and we had MR vaccine at 9 months. So it was very important.
Correct. So I would just want to make 2 remarks here that when the UK was the first country to abbreviate the schedule for HEP vaccine. It used 3+0, drop the booster. 1 dose saved is millions of dollars saved. But they started seeing breakthrough hip disease in the 3rd year of life. So they realized the booster is important. They reintroduced booster and the disease disappeared. So when it came to PCV, they were smart. They made 2+1. Now with that, 6B and 23F had a lesser seroconversion of around 80-85%. But because there was such a massive herd effect, that those vaccine serotype did not matter to lead to disease in non-vaccinated or even in vaccinated till 1 year. And they gave booster early at 12 months and then rest everything is covered up. So they were the first to show. And now with massive use of 20 years of PCV7 then 13, those 13 serotype have vanished from the community. So they can afford to even give 1+1. But in our country, I think the 14 weeks and 9 months schedule was by Professor Madhi's group studying PCV9 which was PCV7 plus type 1 and type 5 in South Africa, as Dr. Manish said. When they used this as 6 weeks, 14 weeks, and 9 months, for 6 years in non-HIV infected, it was as good as 3+1. So I think one dose saved in India 27 million or 25 million birth cohort. If everyone actually gets it, you save 25 million doses. So that's the advantage and the disadvantage of using it. Can you use it in your day-to-day practice?
No, the schedule in the day-to-day practice, you have to offer whatever is the best to the patient. And
Correct.
most studied and the IAP recommendation is 3 primary doses 1 month after
Still,
booster.
correct. But suppose, I mean,
Public
see, in UK and other European countries, after use of many years of national schedule, the disease disappeared, they could afford to make it 2+1 to 1+1. Maybe in our country now, with our own PCV being scaled up so high, in the next 5 years, you never know, IP also may take a stand. You may use 2+1. But as on today, you should use the
and reporting for this.
correct. So you should use a schedule which is approved on the product insert and by the IAP, which is 3+1. All right, I'll ask you one last question. If suppose a child comes after receiving 2 EPI primary doses, 6 and 14, and at 6 months they said, no, I want to switch to you now for all other vaccine. What will you give him a third primary dose or wait for 9 months for the booster? Or what will you do?
Convert this into the IAP schedule because, as I said, we have to offer
Correct.
test in the private practice.
Suppose such child comes at 8 months.
8 months.
Yes. Now another 1 month you can take the booster.
One dose, primary dose, and booster after 1 year. If he
Very
comes
good.
completing the 9 months booster, no further
Okay.
doses.
If he comes at 9 months.
So if he has completed the EPI schedule, no further.
No, 6, 14. He has taken 6 and 14. He came at 6 months, you said, I'll give one more primary and a booster in the second year. If it comes at 8 months, you said, I'll give another primary and a booster at 15 months. If he comes at exactly at 9 months or a little more.
One other primary and a booster at 15 months.
Dr. Chetan, do you agree or you say you only just the booster?
So it's really a dicey situation because suppose the patient has been receiving the vaccine at my hospital or a government hospital. Ultimately, it's the same 2+1. So he
Correct.
finishes the course. But as
Correct.
far as we are concerned, we are not allowed to give it. We say maybe we give one more dose because we see 0.35 microgram is the cutoff. That is right, but it's for invasive pneumococcal disease. When we talk about the otitis media and nasopharyngeal case, definitely we need a higher concentration. So that is the way in between. But I think 9 months I would like to give one dose and forget about it.
Okay, Jitu. So you say you will give only one dose, not give the booster in
So
the
it's the
second year.
same thing. It's
No,
the same
I am asking you, what you will do? Tomorrow patient is in your clinic, what will you do? Manish says that even at 9 months, I'll give one more primary and a booster at 15 months. What will you do?
I will give more one dose 1.5 years.
What will you do, Jitu?
Yeah, same, sir. I will give one dose and then after 1 year, one more dose.
Okay, I will just give the 9 month dose. I won't give any further dose because there's no point in the 9 months itself is a booster at, I mean, you give it at 12 months or 15 months or 9 months, doesn't matter. If it had come earlier, I would have given with the third primary. But if it now comes at 9 months, maybe I would give him only one dose. Because the fact that he could not afford, that's why he went to public health, right? So I would try to ask him to save that money for some
Now
other
he is
vaccine like
affording. That's
varicella.
why he is.
I
So you
told the
don't know
same.
he's affording or why is he coming to you? Okay, but
I
both
told the
answers
same
are
thing,
right.
but couldn't hold on.
Both right answer right. I mean, you can give 2 more also, but at least give the 9 months dose. I
Yes,
think.
yes.
All right. So we have finished discussing 1, how do you select a PCV? 2, how does a new PCV license compare to and what data you look at? And 3, what schedule you use? So in private practice, you will use 3+1. Now let's discuss the vaccines thread by one. Let's discuss first the so we are only discussing the new vaccine. We are not discussing GSK 10 variant. We are not discussing PCV 13 of Pfizer, which has absolutely excellent and extensive data on safety, immunity, and impact data. There is no question. So let's discuss the first Serum Institute of India vaccine, Jitu. Why 4, 18C and type 3 are not there in this vaccine?
Yeah. So PCV10 made in India vaccine, which is a newer PCV, newer PCV10, what we call. They did a kind of smart thing. They removed strain number 3, 4, and 18C, and they put 6A and 19A in their vaccine.
Okay.
So the reason for that, what they did this is because ACIP and basis study were showing serotype 4 as less than 1% and serotype 18C as less than 0.8%. So really, it's not very significant number. Secondly, the serotype C, serotype 3, which causes parapneumonia. There are different 8 studies which have shown that there is either no effect or, in fact, vaccine failure with serotype 3 containing vaccine, and the incidence remained same in those 8 studies. So they decided to drop serotype 3 also. And they decided in removing these 3, they smartly introduced 6A and 19A, which was very effective, because 19A, which was not there in GSK PCV10, that was not, they were claiming that it will have a cross protection of 19F with the 19A, but in real world, there was no cross protection with 19A. And
so I will put it in the current perspective, is that when PCV10 by GSK was being made, PCV7 was in market, and Pfizer believed, why at that time believed that 6A will cross protect by 6B and 19A by 19F. GSK was making the vaccine by adding the serotype which are required by WHO for developing country 1, 5, and 7F. So they added, and they continue to believe that it will work. By the time the vaccine was out, the data came that actually 19 doesn't work. So they were sort of caught off guard. So it's not that they didn't want to. If you ask them in retrospect, they would have also
they were
added.
planning, and they have to opt for PCV10.
Correct.
So the Sierra study and all showed that 19F is not cross-protecting, and the cases in those Latin American countries were increased where GSK vaccine was used. So 19A was directly used in serum PCV, and same about 6A, that it offers a direct protection. There is herd immunity, and cross protection with 6C also is there with 6A. So serum introduced 6A in this vaccine.
So we'll discuss 6B versus 6A when it comes to PCV14. We'll reserve that, because it's not as simple as you say that one is like 19F, 19A. There is no doubt. There's no cross protection. We will reserve that later. So as I understand, this
point of time they did an optimum thing.
Correct. So serum actually is only a manufacturer of the vaccine in India, but the serotype was decided by the 10 commonest global serotype from the developing country perspective, because WHO wanted a third world country to make a PCV. They know it will be always cost effective, and they will be able to procure it for, and 10 million doses for next 10 years, like huge data, huge number of doses that serum vaccine will be used in the international market through UNICEF for the developing country. Okay, so how was it licensed in India? Based on what?
Yeah, so sir, when they were licensing globally, the Gambian study was used for a global licensing. That is a 3+1 study where IgG levels were seen, and they were compared, as Chetan Trivedi sir said, the non-inferiority they proved, and the safety was there. So, globally there was a 3+1 schedule was used for global licensing. But in India, DCGI said you have to do study here only, and 8 sites were selected, including Pune and all. And in those 8 sites, almost 500 children were enrolled, and 3+0 schedule they
comparator vaccines.
Comparative vaccine was PCV13, sir.
And PCV10 both, because both were available that time in the India, right? Sir. And what did the data show in India?
So this 3+1 vaccine, 3+0 DCGI data of 8 centers showed that with the available strains in this vaccine, it is almost comparable with the and non-inferior with the PCV13 also, and with PCV10, one of the 7 out of 8 common serotype, it was in fact superior than that.
Superior, okay,
and one of the 19F, it was a little less, but otherwise it was superior to PCV10, which of GSK. Perfect. So this was the result. So DCGI gave the licensing.
So the serum vaccine in the Gambia was done in phase 2 trial, comparing 3+1 at 6, 10, 14 and at 15-month booster. Their phase 3 Gambian data compared with PCV 13 and 10 both, but using 6, 10, 14 and a early booster at 9 months. And in India, 3+0. And as you said very rightly, in India, it was found to be better than PCV 10 of GSK for many serotypes, and as good as the PCV 13, at least on the OPA. Though seroconversion wise, on IgG, 3 or 4 serotypes were inferior. I mean, they did not pass the non-inferiority criteria, but on OPA, all the serotypes were the same. So that's how to license. Now the question is, in India, this 3+0, though there's data from Gambia on 3+1, Is there any other data in the toddlers from India
Right,
as far
sir.
as
So,
serum vaccine is concerned?
yeah, so Serum did a toddlers study where more than 1 year of children were enrolled who have not taken any primary series vaccine, not a single dose. And
Correct.
they offered 2 doses to these children. Almost 108 children were studied in 3 centers in Pune and Chennai.
And compared with?
With this, they proved that this is also.
No, compared with which comparator vaccine?
This is compared
PCV13.
with PCV13 only, sir.
Correct.
Yeah.
And what are the data? What did it show?
Yeah, so with this 2 doses, there was no difference in IgA and OPA titers with PCV13. So toddler data also was useful for
Correct.
using it in up to 2 years, and that's how our ACVIP said that it can be used up to 2 years.
Correct. So I want last 2 questions on PCV10 from Serum. Number 1, what is the label in India? Then we'll come to ACVIP and WHO.
Yeah.
First is Indian label.
So ACVIP is 3+1.
No, Indian label. India. Label in India. Label means DCGI approved label. Product insert.
Sir, 3+0.
3+0. And there is no upper limit for the 3+0. So you could actually use up to 1 year.
Right.
Because you use 3 if child come before 6, or 2 if child come between 6 to 12 months as primary. Basically, it is for primary doses.
Right.
Then what about IAP ACVIP? Why does it say you can also use as booster?
So ACVIP used this toddlers data as well as booster data from the Gambian study,
Gambia.
and both showed that it up to 2 years, if booster is given, then it can
Correct.
be used.
And what about WHO and international licensing?
So as I said, international licensing, they presented 3+1 data of Gambian study, and
Correct.
with that they got approval for
3+1.
2 years. Yes.
So Serum's vaccine is licensed as 3+1 by WHO, as 3+1 in many other countries as international licensing. 3+0 is a label in India, but ACVIP based on WHO and international licensing and the Gambian data and the toddler data, I said very boldly and very rightly that you can, even in India, our members can use it as 3+1. Okay. Now government is using as 2+1, right? 6 weeks, 14
Right,
weeks,
sir.
9 months, as Dr. Manish said.
Right,
Is there any data on 2+1 in India?
Sir. So, Government of India requested Serum to conduct the study before introducing in the government schedule 2+1 data because of programmatic. This thing they were planning at 9 months. So, 2 primary doses and third dose at 9 months. They asked this Serum to do the study. Actually, the Gambian study was done on this date. This also at one center where 660 children were enrolled. Similar study was done in India with 330 children enrolled with 2+1, and it showed that the.
So any of the data is available for review, like either the Gambian 2+1 or Indian 2+1 or both?
Yes, sir. So Gambian 2+1 data, as I said, published in Lancet in 2023, and it is.
Was it as promising? Was it as promising?
Head-to-head comparing with PCV13 and PCV, all 3 WHO pre-qualified vaccines were compared neck to neck, and it is very promising, sir.
Because as I read from the Gambia, the OPA titers were missing for 4 out of 10 common serotype between PCV10 of serum and PCV13 on the titer ratios. Of course, OPA, there is nothing like a recommended cutoff for non-inferiority, but that was the only setback which I saw. On IgG, of course, it found to be non-inferior. So just to recapitulate, Serum's vaccine is a locally made vaccine globally. Serotypes were decided not by India, but by a platform of international agencies. They took the 10 common serotypes seen in the developing world. They included those. As far as India is concerned, dropping 4 and 18C brings it down by 2%, but by adding 6 and 19A as compared to GSK's vaccine, it brings it up. So between PCV13 and PCV10 of Serum, there is not more than 2 or 3% difference in the serotype coverage. Both the Gambian data and the Indian data found that it is better than PCV10 of GSK in many serotypes, as good as PCV13 in most of the common serotype, including in the toddler data, and that's why the label is 3+0 though in India, but ICVIP has said you can use 3+1 and international also 3+1. We will not discuss 2+1 schedule in great detail because anyway we are not using 2+1 in our day-to-day practice. So good vaccine, locally made global vaccine. Chetan bhai, you want to say something?
I want to ask one thing. When you said that there are few serotypes which were not proving non-inferiority by IgG.
No,
Okay,
not by OPA.
no, even IgG when
On 2+1 you are saying, or on 3+0?
3+1.
3+3
There are
plus 0?
three or four serotypes which are not. When you said no, that serotype is not non-inferiority proved for this thing IgG, but OPA titer were
Yes, correct.
good,
That
right?
is in the Gambian and in the Indian data on IgG, 4 of the common serotype with PCV13 did not meet the non-inferiority criteria, but on OPA the same serotype were as at
Matching.
par.
So what I want to highlight is the non-inferiority has to be proved 0.35 microgram per ml as a whole.
Overall, yes,
Overall,
I
not
agree.
for serotype by serotype. That is
Absolutely.
important.
Absolutely, I completely
Overall.
agree. So DCGI doesn't look at every serotype by serotype. Correct. All right, now let's move to Chetan by PCV14, another Indian vaccine from Biological E. Why add 22F and 33F?
So now what we know is 22F and 33F, they have been called emerging serotype. Now what is
What does it
emerging
mean?
serotypes?
What
That
does it
means
mean?
suppose if you start using PCV7, that vaccine serotypes which have been part of PCV7, that will definitely get controlled. But those vaccine serotypes which are not part of the vaccine, that is called non-vaccine serotype, that will start showing up in nasopharyngeal carriage as well as a disease.
Of the
So
remaining disease.
of the remaining. So what
Okay.
happens? Suppose you have a PCV7, right? We are given. We know that 19A came up gradually. Similarly, PCV10 of GSK, the country is using PCV10. 19A definitely it was a predominant serotype which was remaining. But of course, at the same time, 3, 22F and 33 also were going up. Similarly, those countries who were using PCV13, Prevnar, there the remaining serotype, major chunk was 3 and 22F and 33. So these are the vaccine strain. They have been coming under pressure because of the vaccine serotype, and these serotypes they are coming more and more in remaining. So as such, the data of 22F and 33F not much, but when you see that remaining serotype, it makes a sizable chunk, maybe 3 to 6 to 7% of the remaining
Correct.
serotype.
So as do I understand that currently 22 by 30 make less than 1% of the serotype seen in
1 to
IPD children
2%,
in
yeah.
India, but once PCV is successfully used for say next 5 or 7 years and this vaccine serotype will disappear, the remaining disease burden 22F 33F will become a significant chunk.
So once you have a good coverage, like vaccine coverage, this
Correct.
issue is going to come. And I think India is very rapidly progressing towards the good seroconversion even of PCV because we are giving 2+1.
Okay, see now type 3 is there in PCV13, type 3 is also in this PCV14. Is not there in GSK's vaccine, is not there in the Serum's vaccine. Is there any data that the type 3 actually works even with say PCV13 of Pfizer?
So there are the data, but it is all case control study or something like that, which are not having that real value of the studies. And if
So
you
what
see
does
in
WHO
2000,
say? What
so
does WHO say?
WHO also says that this serotype the protection is not sufficient enough. And even Ron Duggan in his own paper, because we know that Ron Duggan has worked for his PCV7 and PCV13. He also, when he's discussing the immunogenicity, he has been discounting serotype 3. So practically, though it is a very important vaccine, but we are really not able to crack
So we
shell.
are not still able to get the best type 3 vaccine as on today, though it's there in most of the vaccine, but it may or may not work. Mostly it doesn't work. All right. Now,
many.
Yes, Jiddu?
There are many vaccine failures with this 3 strain.
Correct. So that you said there are 7 studies they have all shown that there is no meaningful or actually zero protection against type 3 with 3 containing vaccine like PCV13. Okay. How was PCV14 licensed, Dr. Chetan, by in India?
So PCV14, we know that it is PCV13 plus 22F and 33F minus 6A.
Correct.
So this is what PCV14 is all about. Correct. Now this license based on the definitely phase 3 trial, which was a pivotal trial, where it was almost 6 to 8 weeks infants were given at 3 doses.
So again 3+0?
So it was 3+0, yeah.
Okay.
And it was compared to Prevnar because it was the only vaccine which was available in the Indian National Immunization Schedule. As compared to Pneumocil, what happened at that time, 2 vaccines were there in the private sector. It was not in the government sector.
Perfect.
So they had to compare the DCGI said just to compare it and prove the non-inferiority to existing brand, which is Prevnar. So they did it around 1,200 people. Half of them they received the PCV13 Prevnar, and half of them they received Nubivax, and then PCV14, and then they tried to see what is happening to non-inferiority
So based what was the result?
So they could prove that 12 serotypes out of 13, which were common serotype between Prevnar 13 and PCV 14, they were non-inferiority was proved. And
Correct.
because we didn't discuss that, suppose you don't have the vaccine serotype in new vaccine is having a 2 additional serotype. Where
Correct.
to compare? You have to compare the serotype which is performing minimally. So
Correct, I
seroconversion
understand.
very poor. Suppose 3 is not performing proper, so you take it and then you compare as a non-inferiority. So
Correct.
that is a zero conversion rate percentage. You have to see, you have to prove the non-inferiority. Of course, the GMC titer also been, that is non-inferiority was proved because it was above the 0.5, which is a cutoff of non-inferiority. At the same time, they also did the OPA titers, and they were all comparable to existing brand. So looking at
Correct.
this phase 3 trial, it was given a DCGI give the approval. Approval was for 3+1 because that was what it was studied for.
3+0.
3+0. Sorry.
0.
3+0.
Correct. We already discussed 19A when Jitu was discussing PCV10 visa of Serum vis-a-vis PCV10 of GSK, because Serum has 19A where GSK didn't have. Prevnar 13 of course has, and even new PCV14 has. And I just to tell you the story that after the introduction of PCV7, when it was being made, it was believed 19F will cross protect 19A. But after the introduction of PCV7, the disease incidence fell from 90 per 100,000 in children below the age of 5 years in USA to 15 per 100,000. Massive decrease. But of the 15, 8, that is 50% was 19A. And before vaccination, it was 2 per 100,000. So it went from 2 per 100,000 to 8 per 100,000. That's fourfold rise. And that's because 19F did not cross protect 19A. So now the jury is completely in and out that 19A is required in the vaccine and it is there in this vaccine. Okay, now the question, it doesn't have 6A. Does it mean 6A will not work at all, or there will be significant cross protection between 6B and 6A?
So now this 6A story is very interesting as 19A story. What we saw is 19F is not giving cross protection in 19A, right? That has been proved beyond doubt. Now 6A, suppose your vaccine is having 6B, whether it gives a cross protection against 6A or not, that is the question. Now this we have PCV7 original trial because it was approved in USA 2000.
Correct.
And in 2006, there was a study which was done for initial 4 years effectiveness data.
Correct.
What they found that this PCV, the serotype 6A, that is getting us almost effectiveness in the terms of 76%, which is as compared to the similar of the other serotypes. So that is proving that 6B is giving cross protection almost similar to the vaccine serotype. Then came the PCV 13, that is Prevnar. So those countries who were using PCV 13, like Israel, UK, USA, they started using PCV 13 in place of PCV 7. But before they started using PCV 13, the 6A incidence was going so down, it was been almost very minimal with the help of the PCV 7. So PC 6B gave the cross protection. And similarly, if you
so
see
that's
the
IPD. What about otitis, carriage, indirect effect?
Okay.
Is there going
So
to be a
there
good
are
cross
there is
protection?
two more things. That is, one is otitis media, right? And one is the nasopharyngeal carriage. So in otitis media, there is a study from Finland where they tried to dig out that those patients with otitis media and they have been vaccinated with PCV7, what is happening to them? They actually took the pus from this otitis media and cultured them. And what they found that this vaccine efficacy was against 6A was almost 57%. So that was being like giving a confidence that it might be can be used for otitis media.
So there was good cross protection even in otitis media, which is a mucosal disease, not an invasive disease.
Correct.
What about carriage?
So nasopharyngitis is a nice study which was done in Pakistan. So Pakistan, what they did, they gave 2, 4, 6, and 12 months of the one side PCV7 and another side they gave this thing hepatitis B as a placebo. And they tried to see what is happening to those patients who are having otitis media. They checked the nasopharyngeal swab. And then in that they found that even 6A getting cross protected because of 6B of PCV7 in the tunes of almost maybe 57, 58%. So this otitis media also, it is giving cross protection 6B, and similarly this nasopharyngeal carriage also. So that has been quite reassuring that 6B is giving.
So does it then lead to also herd effect as much?
Now the herd effect is not really unless you have the vaccine coverage which is going very high, you may have that herd effect. But
no, like these countries like UK, US, and Israel, which use PCV7 followed by PCV13. What happened to the 6A disease in the non-vaccinated population?
Correct. So they had the two cohort. One was less than 5 years, another was more than 5 years. So what they found, the disease burden of the 6A is also going down in less than 5 as well as more than 5. So
Correct.
we
So
know
there
that
were herd
with
effect.
one person vaccinated, you get two more protected. That is the herd effect. And
Correct.
that's why 6A also went down in the non-vaccinated group.
So as I understand from your talk, based on the data from PCV7, which did not have 6A and only had 6B, it had shown a good IPD protection of 76%, not as high as 95% that is seen by other serotypes. It showed a good protection in otitis media in Finland. It showed a good decrease in the nasopharyngeal carriage and a herd effect. So it's not that 6B, 6A being not there in PCV 14 or B, the 6A will not work. It will work not as much as if there was 6A, but reassuring that it will work to the tune of almost 75 to 80%. Now WHO protocol says, or the position paper, that if you have 6C in your country, you should use a 6A containing vaccine. Now, what is a 6C?
Now, this is interesting. 6B gives cross protection against 6A.
Correct.
6A gives cross protection against 6C. Now,
but
you know
6B does not cross protect
so
6C.
6B does not cross protect against 6C. Now, when we talked about the 76% protection with 6A, at that time, 6A which were picked up, there may be few 6C also.
Correct.
Now they realize maybe because of that, it was not totally been giving a good result. So 6A giving cross protection against 6C, 6B is not. Suppose your country is having a data where the 6C is a significant number, then you should always pick up the vaccine with 6A only, because 6B is not going to give the cross protection against 6C.
So there's a very recent 2024 paper looking at different countries using PCV13 vis-a-vis PCV10 of GSK and PCV7 in the past, and what happened with the 6C disease. The 6C disease itself is less than 1 per 100,000 before any vaccination, after any vaccination. So though theoretically 6A is important from 6C point of view also, but 6C itself is so low in incidence that practically it would not really matter if your vaccine didn't have 6A, and if there was a good cross protection by 6B versus 6A. Is that the good summation?
Yeah, so that you need to choose the best possible and maximum possible coverage with the effectiveness.
Okay, now the question that as Dr. Jitendra said, for PCV10 of serum, there's a data from Gambia on 3+1, early 3+1, and also that's why the ACVIP and internationally is licensed and given as 3+1. But with PCV14, is there any booster data?
No, not really. They don't have as of now. As of now, there is no data of the booster.
Is
as of now,
data?
When we are talking on 4th of April 2025, there is no data published.
Is there any toddler data?
So toddler data, they don't have the phase 3, but phase 2 trial, which was done between 12 to 23 months of older toddler. They gave head-to-head with PCV13 and this PCV14, and they have data for toddler, and that showed that non-inferiority, or the rather enough of the immunogenicity with the toddler data. But there was very small study, because maybe around 60 each in each group.
Correct. Now the last two questions on this vaccine, as with the PCV10 of serum, what is the label in India? What is the label as far as ACVIP is concerned?
So I think a label in India is 3 primary series, 3+0. 3+0.
So ACVIP?
ACVIP, I think they have not taken a stand. Maybe they will be taking it. They are still sticking to that product insert only. So 3+0.
Also, because there is no data from anywhere on a booster dose, neither from Gambia like with PCV10 nor in India, but a 3+1 study is ongoing.
Yes.
As a phase 4 trial by Biological E, that data will mature in the next 3 to 4 months. And once that data is available, that will make it easier to understand and maybe approve this vaccine for use for 3+1. So till the time that happens, suppose children who have received 3 doses are now due for booster, what will you do?
So that is why actually we can't give it, but it can be off-label use, because we have data toddler. That is one thing. And second thing is you can give the other licensed vaccine in place of.
So which one you will use? You will use serum vaccine, GSK vaccine, or you will give PCV13?
I would like to go for PCV13.
Perfect.
Because that will cover 6A, 19A, as well as it is having incremental, not actually incremental value, but at least nearer to PCV14.
Okay, Jitu wanted to say something.
Sir, now PCV14 is procured by government also.
Correct.
And they are using it in 2+1 series at 6 and 14 and 9 months.
But only 9 months, not in the second year.
Yeah, so 9 months can be considered as booster.
Okay. That's a smart move. All right, we move to the third and the
So,
last
and
new
sir,
PCV. Yes,
sir, there is
Chetan?
one latest information that the 2+1 schedule that has been already been results have been ready, data on file, and they'll be present.
Correct.
Data will be presented to SEVIP maybe by tomorrow. So once
Okay.
you get that, so that will give a confidence about the 2+1 at 9 months, not a
So,
real booster, but the booster data will come in by the August.
so maybe in the month of December, when I do the last Samvad, probably we'll come back maybe for 15 minutes on the 2+1 of PC of BE14 vaccine, 3+1 of BE14, and the next vaccine that I'm discussing with Manish, the name new PCV13 from China, marketed by 3 companies. We'll also have some more data. So Manish, what is the new PCV13? Carrier protein different. Does it matter? What is the carrier protein and does it matter?
The newer PCV13 is a tetanus toxoid and instead of CRM 197.
Correct.
So
So does it matter whether it's tetanus toxoid or CRM, or it wouldn't matter?
it really doesn't matter actually with
Can
the
you name some other vaccine using TT as a carrier protein?
H influenza B.
Any other vaccine which are using tetanus toxoid as a carrier protein? Like we had a hip TT, hip
Yeah.
vaccine. We also have typhoid. We have
Typhoid.
polysaccharide from Bharat Biotech using TT. So there are vaccines using TT. There's nothing wrong. All right. What is so? What these 3 vaccines have been
Menectra
brought?
also.
Pardon?
Menectra.
Menectra. Yeah, now the
Sir,
Menectra, by the way,
DT.
switching as a Menquadify with TT as a conjugate rather than diphtheria toxin. So that's third vaccine. Perfectly said. All right. So this is just for the viewers. There are 3 vaccine with different brand name with 3 different manufacturers, which are actually the same vaccine. For the which it's a Chinese vaccine brought to India. Trial was done initially by GC Chemie. Is available as Vaccimune 13. Is also given marketing right to Dr. Reddy's, which is Pneumogard 13, and it is also going to be now marketed by Lupin as Pneumococ or some such name. I don't remember because I think the vaccine still I have not seen, but there are 3 brands. So how was it licensed in India, Dr. Manish?
It was licensed after the phase 3 trials were conducted in Indian population. Non-inferiority and immunogenicity, the comparator was PCV13 of Pfizer. And it was given in the 3+0 schedule with the 3 primary doses at 6, 10, and 14 weeks.
Correct. And what are the data?
So data showed that all the serotypes with the PCV13 already licensed vaccine, it showed the non-inferiority and good immunogenicity for all the serotypes.
So it was non-inferior on IgG seroconversion as well as IgG titer ratio, and good OPA seroconversion, good OPA titer comparable with the PCV13 of Pfizer. All right. Is there any booster data from India?
There are no booster data from India. The data for the booster studies is available from China. In China, there were 2 studies which were conducted, phase 1 and phase 3 studies were conducted in 120 and 2076 subjects respectively, and the age group was 2 to 71 months. And there the comparator vaccine was PCV7 because at that time only the PCV7 was available.
Perfect.
They found that all the shared 7 serotypes between the PCV7 and PCV13 TT made the non-inferiority threshold, and remaining 6 additional serotypes had the superiority threshold. But only in the older children between 12 months to 23 months, the 19A didn't meet the superiority threshold. And in 24 months to 71 months, both 6A and 19A didn't meet the superiority threshold.
Okay. So primary in 6, 10, 14, it looked as similar, but only thing the schedule was either 2, 4, 6 or 3, 5 and 3, 4 and 5 months. So not the 6, 10, 14 schedule as we use in EPI. Whereas the Indian trial had 6, 10, 14 as what we are using in India. Is there any persistent antibody data in the China at least, like after the booster dose was given, 2 years long-term data, which was as good?
I think in the Chinese studies, the booster dose data is available and they found to be effective in long-term, giving long-term protection against all 13 serotypes.
They actually followed the subject for 2 more years after the booster, and they found that the titers persist for all the serotype, which is really something which is reassuring. Okay, what's the label in India? Again, the same story.
It's 3+0. It's 3
3 plus 0. All right. There is an inbuilt 3 plus 1 data which is part of the phase 3 trial, though they have applied for license based on 3 plus 0. The booster data actually collection is over. Now they've just submitted the data to DCGI very recently. And maybe in the next few weeks, the data will be scrutinized by DCGI. And what I understand, the data looks very good. Of course, not available for even for me to review. So you can imagine it has to be top secret. But once the DCGI will scrutinize it, they will put it on the website because it's compulsory for the DCGI to put on website whatever they discuss. And when that becomes available, it will be very reassuring. But then the label will change. Officially on paper is 3 plus 1. And then so what will happen to the IAP SCBIP? Like for pneumocil, based on the Gambian data, they give 3 plus 1. For B, they don't give because there is no booster data available. What do you think will SCBIP do? SCBIP is meeting now, I think this Sunday, to discuss the newer vaccine. What is your guess, Manish, as far as this new PCV13 is concerned? What will they say? Booster 3 plus 1?
I think so, because that's the schedule which is recommended.
So China has the booster data like Gambia had for pneumocil, so there's no reason why that should not happen. All right, any data on 2 plus 1 with this vaccine?
Said that the data has been submitted to DCGI, but
All right.
date available to people.
All right, so I think we have discussed the 3 new vaccines: Serum's vaccine, biologically vaccine, and the new TT vaccine from China, which has now been co-marketed by 3 different manufacturers, 3 different companies in India. So that gives a choice of almost 5 vaccines. The 13-valent vaccine of Pfizer, the 10-valent vaccine of GSK still is available, the 10-valent of Serum, 14-valent from biologically, and now these 3 brands of 13-valent, which is originally a Chinese vaccine. And before we end, I will just want to ask, now that we have discussed this 5 vaccine, what is Jitu why? What is the IPD serotype coverage with Serum's PCV10, 13-valent vaccine, whether it is Pfizer or these 3 different new vaccine, and the 14-valent vaccine of BE? Because you said serotype coverage is important. If safety is the same, country of origin will matter and cost will matter. So first, serotype coverage. What is the serotype coverage for IPD with Serum Institute, GSK vaccine, and the 13-valent vaccine and the 14-valent vaccine?
Correct, sir. So IPD coverage of these various vaccines which are available according to the data which is available, most of them are between 80 to 60%. The PCV13 vaccine is covering 76%. And then the least one is a GSK vaccine, which is 67%.
That's because it doesn't have 6A, 19A both.
Yeah.
But if you add 6A benefit to the 14-valent vaccine of biologically, would it change the scenario?
Sir, 6A anyway, 6B is of PCV14 is cross-protecting. Only thing is little better herd effect we may get. Otherwise, cross-protection is there.
Correct. So as I understand from, we have 4 data set, the ACIP, which has 361 isolates, BASIS, which has little smaller 81 isolates, PDOV, which has a larger 456 isolate, and the review by Dr. Jyotsna's group of last 15 years from 1999 to 2016 with 1300 isolates, it all shows that the PCV13 will cover around 72% to 78%. The PCV10 of Serum will cover 71 to 77%. That of GSK will cover anywhere from 63 to 72%. And that of the biological E will cover around 70 to 75% to up to even 78%. So they all look very similar. Would you agree? So now the question, if they are all almost similar vaccine serotype coverage, I'm going to ask each one of you, what is the choice of your vaccine? So first, Dr. Manish.
PCV13 of Pfizer.
Dr. Chetan, any reason? Why not 14? Why not 10 of Serum?
Robust data for more than 2 decades.
That number is used in some locations for emergencies.
Oh my, what happened?
Nothing.
Okay, go ahead.
Because the real world experience suggests that is the most
So you believe in real world experience and don't give chance to the newcomer. It's like someone who is practicing for 20 years, every patient should go to him and not go to the newcomer.
Nothing like
All
that.
right, Dr. Chetan Trivedi.
It's like comparing Mahendra Singh Dhoni with a newcomer who is a good also, but he has to prove. So the
So what's
Dhoni is
happening in IPL? The newcomers are doing better or the veterans are doing
so
better?
so you can't actually compare whether they both have been having a similar degree, but
Okay,
only
let me ask you a straight question. What will you use in your practice? You will
so,
use only one
so,
or all?
so I will use both maybe PCV 14 and PCV 13 as it because see PCV 10 also because it is not the only the data which is important when you are using in practice. I am private
Correct.
practitioner, right? So I have to look at the so bottom line is whatever vaccine we use, but we vaccinate with PCV. So yes,
Perfect.
you can have a choice of it. Maybe you can have PCV 13, PCV 14, but you vaccinate. So depending upon the cost and everything, we have to look at the
So
choice.
depending upon the cost, what will you use?
Depending upon the cost, I'll use PCV 14.
Okay. What about you, Dr. Jitu?
So,
Now,
sir,
one minute. I am the moderator, so I ask question. You all cannot ask me the question. So
yes, sir. Right.
Finish,
So,
finish.
sir, I'm waiting for PCV 20 actually. So till then, I will use if cost is not an issue, I will use PCV 13 and otherwise serum vaccine I will use.
okay. What about PCV 14?
So, sir, the data is emerging, the strains are emerging. So till then, I can continue
Okay,
using.
you worried about the booster data being not available
Yeah.
still. Suppose the booster data is available after say 3 months. Would it make a difference in your choice of the vaccine?
I would still give some importance to 6A direct protection and this thing.
All right. Okay, so while I said that you can't ask me question, let me answer that question from my end and an honest answer. To me, a PCV vaccine, as Dr. Chaitanya Devi said, no matter you use one, because they are looking very similar to me. I mean, 3% serotype coverage here and there, it does not matter. We don't forget that PCV 13 of Pfizer also was licensed based on immunological non-inferiority. It proved it mental later on by having impact data in the country's use, but it doesn't mean that when it was licensed and the country started using it, there was data available to say this is going to be as good. All right. So that's the point number one. So the new vaccines have to get their due because they have proven their mental of immunologically non-inferior to PCV 13 for which we have a huge number of data. So there is no question about data available for PCV 13, but that doesn't make the newer vaccine any lesser provided they are as safe and they are immunologically as good on both IgG seroconversion, IgG GMC ratio, and a visual impression of the OPA seroconversion OPA ratio. Now, to me, all the new vaccine, the new PCV10 from Serum, the new PCV14 from Biological E, even when it doesn't have 6A, because I give a lot of advantage with the cross protection to the tune of 80%, which to me looks okay, provided your costs are lesser. And the new PCV30, which have come in market, they all look very similar from serotype coverage point of view, except that they don't have data. But as I said, to me, data availability and impact is not important. To me, the titers immunological are important. I mean, I no reason to believe that a new vaccine which has an X number of antibody on OPA, which is similar to the X of PCV13, will not work as good as PCV13. PCV13, of course, go ahead and use it. There is no question. If you use Pfizer's vaccine, there's nothing to discuss. It's just 1 minute. Okay, very good vaccine, lot of data available, use it. But if you have to give the the remaining new player a chance, what will you base it on? The number one, they should have immunologically non-inferiority.
Right.
Number two, they must be as safe. Number three, they must be licensed for the schedule for which you want to use, which unfortunately is still not there for PCV10 of Serum, though ACVIP said because of Gambian data, is still not there for PCV14 definitely, and I will also want to wait because I can't use it as a booster. And the PCV13 of Chinese origin, of course, the data is there from the China. Then the fourth is the cost, and I think cost is important. Today's time, if you ask, even the most affording will go to public health to take vaccine.
Yes,
Okay,
very true.
don't be under the impression that people are affording and they want to spend. They understand. So if you can save cost, being honest to the patient that there are vaccines which are equally good but at much lesser price, give a choice to the patient. If they agree, then use those. If they don't, of course, you have the choice to use PCV13, as is the choice of Dr. Manish. And last but not the least, and I think to me, as a true Indian, to me is be Indian by Indian. If I have a vaccine of Indian origin which is as good as an international brand, I will use the Indian vaccine. And I'm not mixing my word because I strongly follow our Prime Minister's motto of first 5 years as make in India and second be self-sufficient. So if we can be, and that's the reason why you see we have switched to PCV10 of serum, and now almost to PCV14 of B in the national program. And that's a good beginning as far as the PCV is concerned. I think with that, I would just end up by the vaccine in horizon, because this debate is not ended just by the current vaccine. So let me ask Manish, what is MSD's 15-valent vaccine that is knocking at the door? How is it different from PCV13 or PCV14?
Contains two additional serotypes apart from the PCV13 of Pfizer, that is the emerging serotypes 22F and 33F.
So that is same as biological yeast vaccine, except that it also has 6A.
It is
So if suppose you have to choose between PCV13 of Pfizer and PCV15 of MSD, which one will you choose?
the one which contains 6A.
No, between PCV13 of Pfizer and PCV15 of MSD.
I
MSD has 6A. Which one?
I mean, at present, we have to prove that these serotypes 22F and 33F are emerging in our scenario. And currently, it's anyway not available in India.
No, if it's available tomorrow at the same cost, what will you use?
50.
I prefer MSD's vaccine because
Okay, why? Because it has 22F, 33F.
See,
Okay, so 14-valent vaccine has 22F, 33F, and it as good as far as 6A is concerned. Now, what's your choice?
You're catching, sir.
No, I was just joking. 15-valent vaccine of MSD is not available still, but it is a vaccine which is recommended for children. In USA now, they have phased out PCV13, so it's either MSD's PCV15 or PCV20 of Pfizer. What about the Pfizer's vaccine 20-valent, Dr. Chetan?
I think that has been approved globally to use in pediatric population also. But they have different indication, maybe it's from 6 months onwards to almost adults also. So it is given in a schedule of 2, 4, 6, and I think a booster at 12 months.
15 months.
So,
Same as PCV13, except it has replaced PCV13.
Right.
All right. What is the extra serotype coverage as compared to PCV13?
So there are
as far as
8.
Indian serotypes are concerned?
I don't remember.
Another 4%. It becomes 81%
that way.
from 77%. And what about the 20-valent vaccine of MSD, Dr. Chetan?
21
Which is a
valent.
very completely different vaccine, mainly for adults.
It is 21 valent, sir.
21. I'm talking about 21.
So that is having a different, few are been removed, few have been added, and there is a difference in 20 and 21 is serotype 4. So they have very clear guidelines that if you have the incidence of serotype 4 more, then you use PCV20 as compared to 21. But PCV21 is only licensed for the adults only, above the age of 18.
So 13 serotypes are new in PCV21 of MSD compared to PCV20 of Pfizer. So PCV20 of Pfizer still remains a childhood vaccine as well as adult vaccine. Whereas PCV21 MSD is an exclusively adult vaccine. It takes only serotype which are seen in adults, not seen in children at all. So that's the PCV21 MSD. And lastly, there is going to be a vaccine from Aurobindo, as I had heard. Of course, it came in Limelight paper and then suddenly has disappeared. No one talks about it. Dr. Manish, any idea? What is this PCV15 from Aurobindo?
It's again a 15-valent vaccine, and it contains two additional serotypes, which are 2 and 12.
22F and 20.
Correct. So it's not the same as 22F, 33F.
197, which is a conjugate protein. And we have got studies in the phase 3, which is comparator vaccine is PCV13 of Pfizer again. And
correct.
Non-inferior and immunogenic.
But is the data available?
Yes, it's just, I mean, it's submitted, DCJ approved, not yet available.
Okay, fine. So last question to Dr. Jitu and maybe Dr. Chetan, any one of you. Adult vaccination. Dr. Bodalkar asked that are we discussing adult vaccination? So I think we should discuss because we are all octogenarians. Some of them are septuagenarian. So we must know how to protect ourselves. So,
Thank you.
so Dr. Chetan, Dr. Chetan, what about adults in India?
So in India, it has been, there are so many group of the
first
people.
Of all, which vaccines are licensed?
So PCV third, only one brand, Prevenar, has been licensed to be used.
That is conjugate. What about polysaccharide vaccines?
PPSV 23.
So which brands?
So I think PPSV 23.
There are two brands. One is MSD's brand, and also the Vaximune content. GCKME has a PPSV 23.
Okay.
Which is available Vaximune 20. So when you order Vaximune 13,
okay,
right? 13. If you write Vaximune, you may get actually 23, and you'll make a mistake. All right. So go ahead. So how
So
do
in
you use these
India,
two vaccines
so
in
in
India?
India, I think above the age of 50 years, we can give one PCV13, followed by,
Okay.
depending upon the risk, high risk, you have to follow it for PPSV23, one
So
dose.
what are the high risk? Who should take PPSV 23?
Like you have the cardiac condition, you have diabetes, or your renal condition, or liver condition, or immunocompromised. So then you have
Correct.
to use it.
And
That's
when do
it.
you, what is the gap you keep between the two?
So if it is you are high risk, then it is 8 weeks. Otherwise, 5 years. You give it.
Otherwise,
5 years after that. The
no, not the second. Between PCV 13 and PPSV 23, how much gap you keep?
8 weeks.
8 weeks. If it is in
weeks.
high risk.
If you are immunocompromised, or 1 year if you are at risk condition without immunocompromisation.
Acha, 1 year.
And then you give second dose again of PPSV 23.
So maybe after 65 years.
Or after 5 years after the last dose if you are immunocompromised. But for people with at-risk condition, a second dose is not recommended. Okay,
Correct.
someone is using PCV20 of Pfizer. Then how does this change the recommendation?
So then he is done. He should not be given any other vaccine because it has been covered.
PPSV 23.
No, but the thing is, it is depends where it is. If he is going to he is in US. There is a vaccine coverage very good. So there he can afford to take only one. But in India, I think that's the question will be there because whether he has received the previous vaccine or not.
Correct. So in India, as neither MSD is 15-valent F6 available, nor PCV20 or PCV21 available, we only have Prevnar 13 and PPSV23. Anyone above 50, even healthy adults, should take one dose of PCV13. Because a lot of people between age of 50 and 65 may be having at-risk condition like mild diabetes, obesity, etc. without their notice. So it will protect them. For above 65, definitely you should start taking because you are now immunosenescent, not immunocompetent enough as in the past. And anyone who is at risk condition or immunocompromised should also take a PPSV 23. If it is immunocompromised, 8 weeks after the PCV 13. If it is non-immune compromised, then 1 year after the PCV 13. And after 5 years, second dose if you are immunocompromised. And if you are above 65, whether you are immunocompromised or no, whether you're healthy or no, you will take your first PPSV 23, followed after taking one PCV 13. And then you take one more PPSV 23 at 70 years if you by then become immunocompromised or you have some serious conditions. So I think that in general is the use of PCV and PPSV 23 in adults in our country. I will not name, but I know several people who have, a famous surgeon had a pneumococcal meningitis without any at-risk condition, just the age. We have recently a very senior doctor going into pneumococcal sepsis without any condition except mild diabetes. So earnest appeal to all people who are present here who are above 50. Please, 50 years is the time when you start winding up your life because you can't do anything new generally. Whatever you have done, you consolidate. Maybe your children are now well settled or they are on the verge of getting married. So try to wind up your finances also, make your life secure. Don't forget your life is not only money, it is also the health. So when you have less money, money takes off your body. When you have a lot of money, your body has to now take care of the money. So that is the irony of life. So at 50, you take your first Tdap if you have not taken. You start your influenza vaccine if you have not started. Check for your diabetes, PSA for male, for ladies, sonomammography and a pap smear if not done in the past. Then take your zoster vaccine if you have not taken. Take your PCV 13 if you have not taken. And then if you need PPSV 23, depending upon that. And between 50 and 65, if you're going to eat a lot of outside food, also don't forget your typhoid conjugate vaccine. So vaccine are not only for children or for making money for pediatricians, they are also for adults to save their own health. So I think with this, we will conclude today's session. If there are any questions from the audience, I had seen some hand going up. Dr. Atul, please unmute yourself.
I would answer for your last question.
Yes, please.
I distributed between 3 group of public adults. I got a lot of adults for the Prevnar vaccine, so though I gave it for them.
Very good.
I got a lot of migratory population. My children, those who are settled in Mumbai, Pune, and Bangalore, when they come to Bareilly and go to the vaccination, I give the Prevnar 13. But the ones who cannot afford much, I go for Pneumocil, and otherwise in regular Pneumo 14. This is my criteria for that.
That's for
so
children.
all 4 companies that way.
That's for children, right?
Yeah.
Yeah, perfect. Dr.
But for
Bodhankar.
adults, I have a very good number of adults I am giving Prevnar.
Yes.
Very good number.
We heard that. Dr. Bodhankar.
Yeah, thank you, Dr. Nitin Shah. Thank Dr. Jitendra Gawane, Dr. Chetan Trivedi, Manisha Kulkarni for a wonderful. I was spellbound. I was hungry, but in between, yeah, this morning I am out. So thank you. Just one question, Dr. Atul said about Pneumocil. So I think is it approved for more than 2 years?
No, he was saying in children who come to him, he uses a lot of Pneumocil because it's cost effective.
Less than 2
Adults, he
years.
said he will use only Prevnar 13. That's
But
what he
less
said.
than 2 years only?
Yeah, only 2 years. Yes. Neither none of the new vaccines are licensed above the age of 2 years.
Nitin,
all right.
So we are not discussion on patient group. We are all 65 plus, 60 plus. All patients. I am 70 plus. So on your advice, I have taken the single vaccine 2 doses. Then I take every year flu vaccine in May, and I have taken. I just wanted PCV 23. I don't remember taken, but Prevnar I have taken. So how the Prevnar should be taken after 70, after 65?
You should take one PPSV 23. Or when you go abroad, go to USA, take PCV 20 there. All right.
No.
So I think
Prevnar should we repeat every 5 yearly?
No. It's just one dose in your life.
One dose. Okay.
Yeah.
Typhoid.
So I think we will hand over mic to the organizers, and I was happy that today we crossed 400 viewers at the peak of the viewership. Yeah.
All
over to Dr. Amol or
420, sir. 420.
Pankaj is there.
420, sir. 420. Figure was 420.
Yeah. Rishi, go ahead. Conclude the session.
Sanjay.
Yes. First of all, thank you all, Dr. Nitin Shah sir and all the panelists, Dr. Jitendra Gawane, Dr. Chetan Trivedi and Dr. Manish Kulkarni for highlighting and discussing such a good topic of newer pneumococcal conjugate vaccines. So it was a very good discussion and something new. We also got knowledge from which vaccine to use and not. So very good discussion. Anybody has any questions?
Srinivasan sir, any inputs for us?
My suggestion, Dr. Amol.
No input. I
Sanjay
spellbound.
Yes, sir, your comments, sir. Srinivasan sir, your comments.
Srinivasan.
Yeah, I am spellbound. I am just saying, all of you, so clear in your this thing. Of course, message is very clear, and of course, I always admire Nitin's way of conducting all these panel discussions for so many years.
Thank you.
He's still as young as ever. Thank you.
Thank you, sir, for attending the session.
Finally, one suggestion, Amol, Sanjay.
Only I miss his songs. Usually, he's a very good singer also.
Not today, sir.
And next vaccine onward, we'll save some time for his singing.
My suggestion in the end, Dr. Nitin, Dr. Sanjay, Amol,
yes, sir.
You should have, in the end of every series, you should have some slides, something like that, to take a message or print out whatever, because you are doing excellent job. For a practitioner who is busy seeing 100 patients, he just want to know 1, 2, 3, 4, 5 dot, bullet dot.